consultant at Cambridge University's Hospital Foundation Trust, the inaugural Professor of Medicine at the University of Auckland Waikato Clinical School, past President of the Australasian Diabetes and Pregnancy Society, member of WHO Technical Working Group on the criteria for hypoglycemia in pregnancy, and chair of the Diabetes UK Health Professional Education Steering Group. Please welcome Professor Davis.
Okay, good. Well, it's a great pleasure to be here today on a Sunday. It's interesting. So obviously it's thank the PHN for this opportunity to talk with you. And this particular topic, as you will hear, is a major issue in our district. And I'll show you some evidence around that. And it's something that we do need to deal with. So this is very timely to have this conference today. And this is now almost 30 years ago when the World Health Organization said that women with diabetes should achieve a pregnancy outcome that approximates that of the non-diabetic woman. And it doesn't seem to be much to ask for, but as I'll show you, unfortunately, we're not there yet. And this is just someone who I saw just about 2.5 months ago. So she came into our diabetes and pregnancy clinic at Campbelltown Hospital, so 39, and she was 8 weeks pregnant. She'd had type 2 diabetes for 4 years. Her husband actually didn't know she had diabetes, so that was quite interesting. And she'd been in Australia 2 years from Thailand. She'd seen at a hospital for some other illness in 2015, and her random glucose was 11.3. She'd seen a dietitian, she had no medications and was not doing glucose monitoring. She saw the GP 8 to 9 weeks previously, again with just a minor infection, and her sugars were high, and she was started on glucose monitoring, and they're 9 to 19 millimoles per litre. She was commenced on a tablet, and with the referral I had, I still don't know what tablet she was on. And 3 to 4 weeks later, she was found to be pregnant. She wanted the baby. This is the first one with her husband. And she was advised to stop the tablets, and then she was referred to a private obstetrician at 6 weeks gestation. And so she was referred to us with the referral, high blood glucose, please see, with no other information. And the glucose is, when we saw her, 9 to 19, and we did an H1C, it was 9 to 10%. And she had a miscarriage, which was obviously very sad for someone of this age and with diabetes, beyond obviously the sadness that there usually is. So this is old data from 1981, and it's what we used to use to kind of estimate the risk. So she had an H1C of 9 to 10%. So we tell her that she'd have about a 1 in 4 or 1 in 5 chance of malformations. So pretty high. And is that interesting? That stuff down there? Thanks. That'll be good. Good, thank you. So this is now a nomogram that we now use. I think it's actually quite conservative. I think it generally underestimates the risk. Here's the risk of a malformation, an anomaly, and here's the periconceptual A1C. These are the 95% confidence intervals. And you can see that for her, she'd be somewhere between a sort of 3% and about a 13% risk of a malformation. What sort of malformations are we talking about? The most common in diabetes would be a 3 to 10% would be, this per 100 births, would be cardiac. Transposition, I've seen a couple of those at Campbelltown already. I've been there almost 3 years. That's more than I generally would see in places that I've worked. And then sacral agenesis, caudal dysgenesis, much more common in diabetes, almost pathognomonic for diabetes, but quite rare. But we're more likely to see neural tube defects. So here's another one, and this is from elsewhere. So this is a 41-year-old woman, BMI 24 and European descent, maternal history of diabetes, diagnosed 18 months, didn't think she could become pregnant, and she was on metformin 500 TDS, not doing glucose monitoring, saw a GP, and in this particular area they had practice nurses, had the annual review, eyes, urine albumin creatinine ratio, G5P4 with 3 grandchildren, never seen a dietitian. She'd not received preconceptual advice, but then she didn't think she'd get pregnant because it had been many years since her last child. Wasn't aware of the risks, using condoms for contraception, no folate, and was now 7 weeks pregnant. So, in fact, when we look back, she'd had an H1C of over 13% for over 12 months, with no recent HbA1c. And we had to advise the risk of malformation was 25%, and advise the increased risk of miscarriage. She previously had a handicapped child die at 20 months, and she wanted to continue with the pregnancy and bear that risk. I mean, it was irreversible by that point. So we commenced her on folic acid 5 milligrams once a day. So high dose folic acid is what we use. And you know, at 28 days the heart is forming. At 22 days neural tube is forming, and we use folic acid usually from 3 months pre-pregnancy to 12 weeks at pregnancy. And the evidence, which isn't, I don't think, very good evidence, but the evidence is certainly from observational studies that periconceptual folic acid reduces primary neural tube defects by about 62% and may reduce the risk for congenital heart defects. So no harm, some good, and it may also reduce the risk for orofacial clefts. But it may increase the risk of multiple births. And there's other debate around the use of 5 milligrams, but it's what's recommended at the moment. So that's in place. She has got pregnant on metformin, and what we know is that metformin does cross the placenta. So in pregnant women, the concentration in the blood's around 1.05 micrograms per mil. In cord blood, it's about 2/3. So you're getting about 2/3 dose of the metformin that's being given. And it does have the potential to modify fetal metabolism. Animal studies is not teratogenic in rats and rabbits at doses to 600 milligrams, or I've heard recently in nematodes. Doesn't get into their mitochondria. And at 2 to 6 times the maximum dose recommended in these animals, it really does not cause harm, doesn't cause malformations. And there's sort of this partial placental barrier by about 1/3, but not by much. So does it actually cause malformations? There aren't randomized trials to demonstrate that, but there's a lot of observational studies, not that many in diabetes, but in PCOS, then there's a large number of studies, and they all really show the same thing, that malformations, if anything, are the same. And this one was a bit less, but essentially there's no excess risk of malformations. So, you know, we can reassure her on that. In terms of other oral hypoglycemics, then there's less evidence. The sulfonylureas, we don't use these anymore. They do cross the placenta, and we are concerned about them more from the hypoglycemia side, not really from the side of malformations. The new drugs, we don't really even have that many observational studies, that many case studies. So really, we recommend that women do not get pregnant on any oral agent besides metformin. And then they need insulin, which means they need proper pre-pregnancy management, or they need to avoid pregnancy. And I heard the thing about abstinence. That was an interesting concept. So, you know, we told her there's no evidence that metformin is teratogenic, so we could reassure her. It's the underlying hyperglycemia that's harmful. And so what we recommend in terms of metformin, not really the other medications, you try to avoid stopping it, if you do want to stop it, before 8 weeks, because obviously that's when the risk of teratogenesis lies. We commenced on basal bolus insulin. We had to estimate the dose. Had the retinal review, I'll comment on that soon. Daily contact for stabilization, and she had a fetal loss at 11 weeks. So if you look at malformation rates, there's a number of studies around the world. This is Monash. Here's East Anglia. This is in Ireland, in fact. So type 1 diabetes matched controls. You can see about 4% for those with type 1 diabetes in East Anglia and in Ireland. And Ireland also has a bit of a haphazard system. It's not particularly well organised, but the controls are about, as we would expect, around 2%, 1.6%. You can also see some miscarriage rates, but they're quite high to estimate when you don't have people in your clinic. Stillbirth rates much, much higher, 4 to 6 times. Perinatal deaths here, and this is Monash. They had 4%, but I don't really believe it, because they also had 7% stillbirth and 7% perinatal death rates. So I think there are some issues with some of these being actually some malformations. What about locally? So we do have published data from Liverpool, and we've just completed an audit at Campbelltown. And in Liverpool, published 6.7% rate, and in Macarthur, there's a 12% malformation rate, which I think is pretty disgusting, and clearly shows that we do not have in place the sort of systems that we need to put into place to prevent this. This is largely preventable. We should be able to at least be down to 4% like elsewhere. What about some of the other complications? Here's East Anglia, Australia, and here's in Monash, and here's type 1, so polyhydramnios 5 times, neonatal hypoglycemia. If you're good at your maths, that's about 50-fold. Shoulder dystocia, often it's actually more than that. LGA's premature labour about 3 to 4, so it's usually iatrogenic. And neonatal composite of all of these, half of the women had at least some adverse outcome. And in the controls it's 6.5%. If you look at these, the neonatal hypoglycemia was worse at Monash, probably double. Shoulder dystocia, large for gestational age, was 44%, about the same as East Anglia, and here's these premature. So really, the Monash data is pretty poor. Caesarean section rates around the same as elsewhere, twice that of the background. And the thing about these women who get pregnant is it's not just about the malformation and the miscarriages. The women with a poor glucose control, they track all the way through the pregnancy. It's really hard to get it down, and often it's too late, even if you do bring it down, to reverse what happened. But it's often really hard to get that glucose down. They need to have good glucose control and good pre-pregnancy management beforehand. So if you look here, and this is from the UK, here you've got this pale blue. These are the offspring who are alive at 28 days, no congenital anomalies. Here's the H1C. You can see that it goes down as we would expect in pregnancy. The H1C drops for red cell turnover and dilution reasons, but red cell turnover. And then it's quite hard to change it after that. This is still our target in pregnancy, by the way, is 5.6%. So even in this group, the H1C is almost 1% higher than we would like, and you can see the effect of that on the risks of malformations and so forth. These ones here at the very top, these are the ones who were normally formed stillbirths, and you can see they had a high H1C all the way through. As I said, they just track, they just run parallel as a group. These are the ones who had the congenital anomalies. The women put the efforts in, they realise they've got pregnant with crappy glucose control, they do all of this stuff, their H1C comes down to there, so it is achievable, but unfortunately they've still got those babies with congenital malformations. Often people call type 2 diabetes mild. From a pregnancy perspective, that is not the case. The woman with type 1 diabetes and the woman with type 2 diabetes have the same stillbirth rate, they have the same perinatal mortality rate, the same neonatal death rate. So type 1 and type 2 diabetes, whether you're diet managed, tablet managed, insulin managed, this is a very high risk pregnancy. They need to be seen before pregnancy to optimize this. They get to the clinic as early as possible so we can start managing them. So have we evidence that improving glucose control reduces risk of malformation? So how many of you have heard of the DCCT? Only me? Oh wow, that's sad. Anyway, so the DCCT was published first of all in 1993. I mean really it's the bedrock of diabetes management today. Randomized trial of about 1,400 people to either an H1C target about 9% versus 7%. And that was when, in the old days, when people used to be on twice a day mixtures and all sorts of things, versus 4 times a day, 7 days a day to glucose monitoring, close support, and it reduced, you know, retinopathy by about 60% and nephropathy by 30%. That is the evidence why we look for tight glucose control. But within this trial of 9 years that was stopped prematurely, there were 270 pregnancies and 180 women. The malformation rate in the conventional limb was 5.9%. Lots of reasons why, whether you start before or after, this is the pre-pregnancy theoretically in those days, and after conception was still around the same. In the intensive group, 0.7%. So we know that tight glucose control prevents malformations and other adverse pregnancy outcomes. But tight glucose control has its risks. particularly hypoglycemia, and of course weight gain, particularly hypoglycemia. And this is the scary part about trying to manage someone who becomes pregnant with their type 1 diabetes. And what you'll see here is, here's the capillary glucose monitoring. The first thing that happens after women get pregnant is, in fact, their glucose goes up. So here you are, you want tight glucose control, and the glucose goes up. And it's really upsetting for the women who've often planned this, and then the glucose goes up. So we need to have something that allows flexibility very quickly in the first 2 to 3 weeks, 4 weeks of pregnancy, and then it goes down. And at this point, the insulin requirements go down. And for that reason, there are massive risk of hypoglycemia here, and this is where the deaths occur, and the car crashes, and many of those other aspects. So, old, but really unfortunately still relevant today, a review in the UK of something called CMATCH, and there were 7 fatalities from hypoglycemia. A quarter of them didn't have a glucagon kit, type 1 diabetes. The reasons for that were unclear, not hospital policy, considered unnecessary by health professionals. And women were declined the offer a kit in 1 in 20. So, you know, hypoglycemia has to be discussed with any woman who may get pregnant if she has type 1 diabetes, and glucagon has to be made available, providing they've got someone who can give it to them while they're unconscious or whatever's happening. In terms of the proportions, this is a less old study, but from Scotland, about a third of the women had severe hypos at any time with their type 1 diabetes, and most of those were in that first trimester. Associated with duration, smoking, pre-pregnancy retinopathy, and planned pregnancy, because they're running so much tighter. The other thing that women need to be aware of, besides this increased risk of hypoglycemia, is diabetic retinopathy. So this stimulates new vessels and, to some extent, macular edema. And this is a review from about 7 years ago from Denmark. And there, a quarter of the women developed progression in at least one eye. 6 developed sight-threatening progression. 3 loss of visual acuity, basically went blind, and 4 needed laser. I've had 2 women who've been blind, gone blind in pregnancy, particularly if the H1C drops quickly, but that's what you have to do to try to protect the baby. So what about those who've got nephropathy? The prognosis for the mother is generally good, but the risk of preeclampsia is around 1/2. And the risk of cesarean, usually around 50% in type 1 diabetes, 80 to 90%. So these are very difficult women to manage. Risk of retinopathy by about 2/3. And we're still debating about, does it mean that kidney function can get worse in pregnancy, but it goes back to beforehand, and they still seem to track down the line of renal loss that they were on before. But what about the child? About 5%, so 1 in 20 will die. About half are preterm. In Finland, in fact, 21% are under 32 weeks. So obviously with all of the wider cognitive function implications of that. Between 1/4 and 1/2 are growth restricted, and psychomotor retardation, particularly with fetal weight under 2,000 grams. So this is the evidence about the harm that is done. But what does that mean? Can we do anything about it? Well, we have a randomized trial. And in fact, we know that planning is very important, and maybe we could do this. Even that might be good contraception in its own right. We know that at least 50% of women who become pregnant, they say that the pregnancy is unplanned. Some studies say 70%. In fact, when you talk with the women, they weren't planning, but they're quite happy to be pregnant, and in fact, really, they probably were planning a significant proportion of that. It's just that they weren't aware of the risks of becoming pregnant with poor glucose control and fetotoxic medication. So what about that tightening of the glucose and having this pre-pregnancy management? Well, first thing that happened in East Germany, interesting enough, that's how long it's been going on, and then in Scotland, pre-pregnancy clinics were set up. So if someone came to a pre-pregnancy clinic, then basically a multifaceted intervention was put into place, and these are all the studies to date, and you can see that pre-pregnancy clinics are associated with a reduction of about 3/4 in malformations and reduction of about 2/3 in perinatal mortality. So the women who come to those clinics, we know, have far, far, far less risk of these terrible outcomes. And what's involved is a multidisciplinary specialist team. It's not someone sitting on their own somewhere. We screen for complications, review the medications, particularly ACE inhibitors, which are also associated with malformations, of course, and statins, and we switch to safer diabetes medications at least 3 months before the pregnancy is planned for. We stop contraception, or they stop contraception. And the key issues around the individual counselling about pregnancy risks and prevention. And we recently had a Health Pathways sort of Delphi group. Was there anyone here who was at that? So we got 1, 2, yeah, thank you guys, that was really helpful. And the issues around that is clearly, it's quite a complicated process to be able to estimate the risk of someone, go through their issues around their retinopathy and those other aspects. You really need to give them very clear information. And if you don't, then maybe, to some extent, whoever's involved is culpable. Smoking cessation, that 5 milligrams. Glucose monitoring, probably 7 times a day, but sometimes down to 4. You negotiate the targets for H1C and glucose. Generally in the UK the target was 6.1, it's around 6.5%, but sometimes it's pretty clear that if you get down to 6.5%, the person will be unconscious with hypos. So you have to negotiate that very carefully. The glucose targets, we generally use the ones that are used in pregnancy. So we would use 5.3 fasting, 1 hour 7.4, 2 hour of 6.7. That's pretty tight to try to get your glucose while you're driving around above 5, but under 5.3 when you wake up in the morning. That is pretty tricky. Dietitian input, obviously carbohydrate management is absolutely crucial, as is weight management, and they need to understand those risks of hypoglycemia. And as I mentioned, really important to promote early booking into the antenatal clinic, but actually the way that the clinics work here, into the diabetes in pregnancy clinic. Because often we will see the woman before even the high-risk midwife. We hand over to the high-risk midwife or the midwives or anybody else. They need to come to the multidisciplinary diabetes team as soon as they know that they're pregnant, but preferably pre-pregnancy. Yeah.
You need to start making decisions about the oral hypoglycemic agents pre-pregnancy time?
Yeah, before 3 months.
Yeah, I mean, how the decision? Stop the first of the hypoglycemic agent and concentrate on the metformin?
Metformin and insulin. Correct. But that needs to be intensive, and it needs to have the right background behind it and the right explanations around it. Absolutely.
With gestational diabetes, should they be on higher dose?
There's no evidence for that. But I'll come back to women who are at high risk of GDM or overt diabetes in pregnancy later on in my last 2 slides, and I'll comment on that, but not quite relating to that. Unfortunately, so we have these clinics, we know what to do, we know that it works. Is it happening? And this is just a national survey, but in fact it could be in Australia as well. Slightly worse in some areas, slightly better in others. In fact, the proportion of women, even with type 1 diabetes, who get pregnant with high-dose folate is probably at tops about half. And for women with type 2 diabetes, because of this belief that it's some kind of mild thing, then it's only about a quarter, in spite of their equal risks of malformation. In terms of changing those medications, then you can see in type 2 diabetes, it's at least around 8%. Obviously that will vary by your ethnic mix. If you've got people with particularly aggressive type 2 diabetes, more of them will be on more agents. And we have many of the particularly effective SGLT2 inhibitors and so forth now. And women getting pregnant on those, we have no idea what that means. And it's high risk. They should be on metformin and insulin in a way that doesn't put their weight on. So in terms of other fetotoxic drugs, around 6% of those with type 2 and about 1.5% of those on statins, and similar numbers with fetotoxic antihypertensives. So the women who don't come to the clinic, besides those who aren't referred, what sort of women are they? They're more likely to be lower socioeconomic status for a range of reasons. they're more likely to have less education, they're more likely to belong to an ethnic minority, and there's researchers to say that. Is that because of women not being referred, or is that because of choice? Is that because those clinics aren't set up in the way that they need to be? Cigarette smokers and those with a less supportive partner, and those who've had a negative relationship or discouraging advice from health professionals. And this is one that we see again and again and again. And we've interviewed some of these women who didn't attend, many of whom have previously had stillbirths, in fact. And they said actually 25% said it was unplanned. 25%, well, we were less rigorous with our contraception. And 50% were willing to attend but didn't. And these are some of their quotes, without being horrible to the doctors that I was seeing. When I was kind of 17 onwards, had I had someone more approachable, it may have been different. Partner, she didn't like the horror stories, as she calls them. So those stats are pretty scary and horrible. You've got to be very careful how you weave through, make sure the information gets there, but not in a way that's going to chase them away. All the bad things that could happen, I suppose looking back in hindsight, they could have counterbalanced that with all the good things that could happen around, you know, a precious pregnancy. Well, now as soon as you mention the P word, pregnant, they're going to come down on me. Oh, you shouldn't be having it, and that's going to make you feel even worse in the first place. So the words we use are really important for trying to make sure that there is access to the sorts of care that they need. So what about if you try to go wider than a clinic and implement a healthcare professional and patient awareness program and coordinate it? And this is one that was designed by a psychologist, Australian psychologist, and was given out across East Anglia. So that's about 4 million people. So that's a lot of people, multiple services, lots of GPs, and this is the coordinator. So important to have a coordinator. And she contacted general practices. There are primary care education updates like this one. Primary care facilitators, midwives, mandatory training. I can see some midwives over there. And lots of different ways. It's a multifaceted intervention across that 4 million population. And chopped out the results to that. But that intervention was associated with a halving of the malformation rates. So we know that it works. And reduction in perinatal mortality as well. So, you know, every woman of reproductive age should be asked about pregnancy. Every woman with diabetes should be asked about pregnancy, informed of the risks, and really, if you think about it, they've got 3 choices. Contraception or abstinence, pre-pregnancy planning, or at least they have an informed decision to have a high-risk pregnancy, knowing that they've got an increased risk of malformation, miscarriage, and adverse pregnancy outcomes. At the end of the day, if we've given them information, you will know that they will make their own decisions. But at least we've done what we can, as much as we can, to bring the horse to water. And that's really our obligation, to make sure that they have that information. So we've just had a good presentation on contraception. So this isn't just about pre-pregnancy, and as you discuss, a lot of this is not about pre-pregnancy. It's actually making sure that those women do have effective contraception in place, and we want low failure rates, readily reversed, so they've had their time planning, and when they decide to stop their contraception, they're going to get pregnant as quickly as possible, and low minimal metabolic impact. And so really, at the end of the day, what we're looking at from a diabetes point of view, an endocrinologist point of view, is number one, we would be looking for either Implanon, or we'd be looking at Mirena or intrauterine contraceptive device. Those are our methods of choice in women with type 1 and type 2 diabetes. The women will make their own choices, of course. They may decline, they'll hear stories about people bleeding and all sorts of those other things that you all know lots about. But just that you know, they are our first line approaches. Obviously, if they don't want any more, then tubal ligation vasectomy. And you've just heard that otherwise there's progesterone-only pills and so forth. But this is what we would like to see in place. In the States, they're now looking at how if a woman's already had one pregnancy, and while they're still pregnant, they're looking at putting the Implanon before they've had that baby, so when they go out, they've got their Implanon in, and at least we can manage the next pregnancy. So if they're already pregnant, and having had people in my room that say, there's no way I can be pregnant, I sleep downstairs, my husband sleeps upstairs, it's impossible, and I see them 2 weeks later in my pregnancy clinic at about 8 weeks gestation, so I don't trust really anybody. So, you know, so some of them will already be pregnant, and if they do tell you that, then refer to Diabetes Pregnancy Clinic immediately. As near to 0 weeks that you can, commence the 5 mg folate, stop the teratogens, continue metformin, ensure glucose monitoring is in place. And it's to the diabetes service, as I mentioned, not just the maternity service. We're still getting people that come to us who've gone through the antenatal clinic, and then they come to us when they first see perhaps obstetrician or someone, and it's, or the midwife. It's really delaying what we can do, and the women track. We want to see them as soon as possible. Also, if they do miscarry, unfortunately, but if they do, then at least we can ensure that they do have timely contraception, and we can enter them into pre-pregnancy care if that is what they want to continue on. And I find most do, but not all. So if they're down the planning limb, so they need their individual counselling about pregnancy risks. Health pathways, is Ben here? Ben, you here? He's outside, okay. So Ben, there will be more documentation on health pathways. So you go to health pathways and you can have a look, and we'll have more information on there as well. The LHD has funded pre-pregnancy services in different ways at the moment, but as we get more volumes, these will be full. We've got one already as a full pre-pregnancy clinic, dietitian, educator, endocrinologist, near where the obs and gynae people are, if that's what we need. And Liverpool also has one which is embedded, and Bankstown will be starting it. So this funding is in place for those pre-pregnancy clinics. And then obviously we want to go wider than just those clinics. The evidence is that those coming to those clinics do well, but what about the others who should have access? For a range of reasons they don't come. So in southwest Sydney, we've been working on for, I don't know, about a year. I don't know how long, it must be about a year since we've been talking about it. And it's taken a lot of work. We've interviewed women, we've interviewed GPs, we've interviewed specialists, both private and public. We've interviewed partners. We've had some groups together to discuss this. So we have our pre-pregnancy clinics. Health Pathways is there. We now have leaflets, which will go up on there as well. There are apps that are available, which have been adapted in Queensland from something that came out of Denmark. So there's actually something available there. And we will look for every single way to make sure that information is accessible, providing someone knows that it's there and is looking. And that's our issue. And part of that is making sure that people understand about pre-pregnancy planning. And all of you in this room, are you all from southwest Sydney? Anyone not? That's good, just checking. So, so all of you have access to free CPD online. And this is either through the PHN or through the person who's coordinating, who's Therese Fletcher, who is over there. Therese, do you want to stand up? This is Therese. So we're distributing the tokens. They're actually just a password. You all have access. The pre-pregnancy topic is only 6 questions. You go in. If you know everything, you can do it in about a minute. If you don't know things, the information is there, and it'll be pretty clear that you don't know because you get some questions wrong. And then you can do those. And then there's a certificate at the end of it, which is there. So this is available now. And you, as I said, you can contact the PHN or otherwise. So in terms of changing some of the other aspects of what's needed, the PHN has kindly agreed to the support of the practice support officers, and we also have a coordinator who's not here today, Mariam. Are you Mariam? No, not here. And we're also looking for another coordinator to do the things that EasyPod did as well, to make sure that every practice and also every specialist clinic is aware of pre-pregnancy planning, what's required, that you can get information from health pathways, and that we need to make sure that the women are aware and have the information. So the first one is quite easy, and we'll prepare a pack for you, which will be practice-based messaging. So you can have those, you know, your little TV screens, you can have that as one. Doesn't apply to many. Each of you will probably only have about 1 to 5 of these women women of reproductive age who are fertile and may get pregnant. There's not many, but you know, it will be there. And posters and leaflets. And then we're trying to work through how do we make sure that every woman is identified either through the specialist or services or your practices. If you want to send things to people, you don't want to send information if the woman, you know, is not going to get pregnant. It's pretty upsetting. It was a cause of some of the complaints we didn't have many complaints, but about one or two, but potentially in EasyPod, you know, population of 4 million, you're going to have a complaint about something whatever you do. So we're looking to be able to send either the leaflet or a website link or the app to those women, so they've all got that information. We need to know who that's happened, where that's happened, so we can assess that. And then essentially we're looking for a triaging, aren't we? Are they in the contraception abstinence group, or pre-pregnancy care, or informed risk taking? And they're in one of those three groups. There aren't any other groups. That's it. So what about women with the undiagnosed type 2 diabetes, the ones who perhaps had GDM last time? So for those, so all women with a risk factor, they're not supposed to have an OGTT. There isn't evidence for that, which is very important because a lot of women are having OGTTs early and we don't know how to interpret that, so it needs a trial. So if they are early, they have either a random glucose. If it's 11.1, then that's basically overt diabetes in pregnancy. Fasting glucose 7, the clinical services, the hospital service will continue with their OGTTs, just that you know over there looking concerned. But for you, this is what we'd like you to do, or an HbA1c of 6.5%. It identifies women, if you do a GTT, with glucose less than these criteria, and we just don't know where to draw the line. There are some studies from China and elsewhere that say, hey look, this is tricky. So do screen, random glucose or HbA1c, and then rather than a test, we have an NHMRC funded trial, which includes Bankstown, Liverpool and Campbelltown. It's got 11 hospitals across Australia. It's NHMRC funded. We're the only people in the world with this trial, so we really need your referral. Many of the women coming to our antenatal clinics were actually turning up after 20 weeks, so we don't know what to do with them. We can't get them into the trial, we missed our chance, and some of them had an OGTT and they can't come into the trial. So what we're looking for is, you know, if they're high risk, they're under 20 weeks, they don't have pre-existing diabetes, then instead of a GTT, do random glucose. This is the one to copy, by the way, if you want to take pictures of this. And I'll give you these as well at the bottom. Refer to your local antenatal clinic as soon as you can, unless they were going to go somewhere else. And then ask if you can pass on her name and contact details to us. We will do the consenting. So really, you can say there's an NHMRC study looking at how to manage women who have GDM early. And this is where you can get more information. You can do that in about 20 seconds. So, you know, I know you've got a room full of people outside. We don't want you spending lots of time discussing it and so forth, because, you know, it needs to be done in a way that will give the full information, and that'll take you quite a lot of time. So, thank you. How much time?
One question.
One question.
Because we have to undo your microphone.
Any questions? Any concerns is what I would ask you about. Any advice about how we make sure those women receive those leaflets and apps? You're all stunned. Yeah, Annette.
The antenatal protocols, obviously, that all.
Sorry?
At the moment, the antenatal care protocols that all practitioners should have a fasting blood sugar. So I'm a bit confused with this.
Fasting, sorry.
75 GTT.
Fasting.
What you're saying fitting in with our protocol.
So, I mean, the GTT, if it's done, that will exclude them from the study. So I think you can discuss that with those women and see if they're not going to be referred on, then do the GTT if they're not going to be interested in the trial. But really, if they're going to be interested in the trial, then we would rather have random glucose and HbA1c. In South Australia, they do random glucose or HbA1c. They don't do the GTT. Within the antenatal clinic, we will do a GTT anyway if they've refused to come into the study. That's actually how we replaced it. The reason why we've raised this is because there's a large number of women turning up who are very late to our clinic and it's too late. And then there's this other group who've had the GTT already, and it means that the number of women we can, right, so we need to deal with the protocol.
We need to discuss that.
We'll discuss that, good. It's interesting, we've been through a whole range of discussions. It's the first time that one's come up. So good, thank you.
I just want to clarify, for the woman to enter, I just want to clarify that for the woman to enter into the trial, they must not have the GTT at the beginning.
Correct.
It doesn't mean that doesn't mean that they should not have a GTT.
Correct.
I mean, clinically, I can do
Correct.
it. Yeah.
You can, but they'll miss the chance of that. And what will happen is that we will diagnose GDM early using the 5.1, 10, 8.5, but we don't know what to do specifically in that range between 5.1 and 7 fasting, and we don't know what to do with the 2 hour between 8.5 and 11, and we will treat and manage them, and they will be in our clinics, and they'll be in our clinics for about twice as long.
A few weeks ago, I received a letter that we need to do GTT 75 gram sugar as an antenatal screening, one of the criteria now with the antenatal screen. And he repeated again on 26 or 28. My question is, the Medicare accept 2 GTT in short period? Or they come and blame us later on? As you know, they do statistics for every doctor, how much pathology he requests.
Yeah, so just as obviously the last one, we will discuss the guidelines locally, number one, and then if they've had their GTT as their first turning and then they come at 24 to 28 weeks, that is what the guideline is currently around here.
Yeah, but that is the guideline for pregnancy, but not the guideline for the Medicare. We need to get the Medicare criteria for GPs, whether we are allowed or they come after, say, 2-3 years. I think it's based on national guidelines.
I've never had an issue.
It depends about the number of the patients.
I think that's it. Thank you very much.